want to welcome everybody to today's topic. Hello, HCCs. And I'm so excited. This is our first dual presentation, if you will. We are going to be hearing from Shay Lunt and Christy Pollard, and I've had the privilege of working with both of them over the last few years. Shay comes from the prophy world. She's our expert in the prophy arena. So she loves to train, she loves to develop content, and then she is one of our primary leads on a lot of the prophy-based audits, so she'll lead that team. And then Christy Pollard, she's been a big presenter, a big developer as well. She does a lot of national speaking presentations. Her expertise lies in the facility side of coding, as well as vascular interventional radiology is kind of her little sweet spot. So I think at this time, I will kick it off to Shay and Christy and let you guys take us away.
Thanks, Kathy. This is Shay. I'm going to start us off today. I'm super excited to be here with Christy today talking about HCCs. So we are really just here to talk about the basics. We're hearing more and more about HCCs, and I'm sure you guys are too. There's a lot of focus, and they are really becoming more common in risk adjustment models and payment reform initiatives that are going on. So diving into the basics, we're going to talk about two different payer models, one from CMS, so Centers for Medicare and Medicaid Services, and then one from HHS, Health and Human Services. We're going to talk about the HCC coding concepts, how codes map to HCCs, and how the hierarchies work within the model. And then we're going to talk a little bit about documentation requirements and which, spoiler alert, they're not too different from what you already know. And then last, we'll take a quick look about the effects on payment. And we have a whole hive of bees in our presentation that are helping us out today. And bees do work in a hierarchy, so we thought that was a good analogy for today's presentation. So risk adjustment is really, it's a type of payment method, and HCCs fall into a risk adjustment model. So this is a process that organizations used to pay health plans for care of their members. So the most prominent example we have is the CMS model. And the CMS model uses risk adjustment in the form of HCCs to adjust payments to health plans like Medicare Advantage or our Part C plans to care for their members. So the health plans are paid by CMS on a per member per month basis, and the payment amount is determined by a formula which takes HCCs or it specifies risk as a factor in that payment. So this is a quote from CMS, but what they're saying is that risk adjustment allows CMS to pay the plans not just an average amount for their Medicare beneficiaries, but they can risk adjust that amount and make more appropriate and accurate payments to the plans based on what the expected cost would be to take care of that member. So it kind of helps them level the playing field and really pay the plans what they should be expected to pay out for the cost of taking care of that member. So there's two main goals of risk adjustment models, and I kind of touched on this, but just to go over it again, the payment, by not basing the monthly payment on an average, it allows for the plan to get proper funds to care for the sickest patients. So it just levels the playing field in terms of the type of patients that a plan is willing to insure. So if you think about it, if they were just giving an average payment out, there's not going to be a plan that's going to want to take on those really, really sick patients. So it accounts for that. It also affords itself to a lot of data opportunities. And what we're seeing more and more is data looking at providers that are demonstrating low cost, high quality care. So with risk adjustment data, we can look at providers who treat a large number of beneficiaries with multiple chronic conditions and really look at their scores in terms of cost and the quality of care that they are providing.
Okay, this is Christy. Well, Shay and I are going to be going back and forth today, and there's a lot of buttons to push to make this happen. But just going over the two basic HCC models that are being used right now. The one that I think most people are familiar with is the CMS version, the CMS HCCs, which are used to cover patients who have Medicare Advantage, or it's Medicare Part C. So these are patients who are over the age of 65. This is a prospective payment where, for those of us on the facility side, we're very familiar with the term prospective payment, where the payments are figured in advance for what will be paid in the future. There are 3 submodels within the CMS HCC plan, and that includes the RX HCCs, which covers Medicare Part D prescription drugs. We have the ESRD HCCs, which you will see for patients who have end-stage renal disease. So I will step back and say that, like Parts A and B, Medicare Part C will also cover patients who are disabled or who have end-stage renal disease if they are under the age of 65. So that's included in this model. And then the PACE HCCs. And the PACE HCCs cover patients who are living in the community, who are eligible for institutional care but are able to live on their own, and it's based on a frailty index. Now, the HHS HCCs were developed for use by commercial payers for any age group, specifically under the Affordable Care Act, and we also see some state Medicaid programs using this as well. This includes coverage for medical care as well as drug spending, and there are 3 different age groups within that. So you've got the 0 to 1, 2 to 20, and 21 to 64, and of course at age 65 then the patient becomes Medicare eligible and could switch to a Medicare Advantage plan or traditional Medicare Part A or Part B. Now, unlike the prospective payment, so in the CMS model, what we report in our current year, 2019, sets the payment rates for next year, for 2020. But in the HHS model, it is considered a concurrent or retrospective payment, in that you get paid for the severity of these patients on a current basis. You don't have to wait until next year. Looking at the submodels from the CMS HCCs, and I will say that we are going to spend most of our time today addressing the CMS HCCs because that's the one that seems to be getting the most buzz. We could do probably a whole other webinar on the HHS model, but today we'll focus on Medicare Advantage. So again, we've got the 3 submodels: the prescription HCCs that covers the prescription drugs under Medicare Part D, and these use a lot of the same HCCs that are in the grand CMS HCC model, but there are not as many, so it doesn't use every single diagnosis that is in there. There are additional HCCs also that are on the prescription list that do not affect the risk for a patient on the grand CMS model. So for example, if I recall correctly, I think hypothyroidism might be one of them, where it's not going to generate a CMS HCC, but because the patient is on medication for that, it will generate an RX HCC if the patient has Part D coverage. The end-stage renal disease is the ESRD HCCs are based on the CMS model. Again, for patients who are aged or disabled, it uses the same HCCs, but not all of them are going to apply. So if you keep in mind that we're managing chronic conditions, you think of all the different chronic conditions that could affect the Medicare population, they're not all going to affect the fact that the patient has end-stage renal disease. So mainly what we're looking at in the ESRD model are going to be the the chronic kidney disease, the different stages, end-stage renal disease, whether the patient's had a kidney transplant or whether they've been or they currently are on dialysis. And then the PACE HCCs. And this is for patients who are living in the service area of a PACE organization, and it's not terribly common. It's not something that I was familiar with before doing some research for today's webinar. And again, these are services for frail and elderly individuals who live in the community, and they're assigned a frailty factor that kind of, it adjusts the payments if they're going to need additional care for being more frail than other people in the model. This, unlike the RX HCCs and the ESRD HCCs, has more diagnoses than the CMS HCC model. And a lot of what is included in that is going to be codes that show or measure the patient's ability to perform their ADLs, so their activities of daily living, to make sure that they're able to continue to live independently. So where do HCCs come from? And I have to tell you that we've been hearing buzz about HCCs in the hospital side only for about the last, I would say, 3 or 4 years. And it's anytime we have talked to our pro-fee friends, they're like, dude, it's all physician. Why are you even asking? But actually, it's not just physician. This does impact hospitals as well, because HCC data is coming not only from physician office visits, but also hospital inpatient and outpatient. So everything that we are reporting on a Part C patient in a hospital is going into this patient's risk profile. The documentation sources that are excluded from this, though, include documentation from skilled nursing facilities and hospice, because those are not hospital, inpatient, outpatient, or an office visit. And some of your basic tests, things that we typically don't code from. I will say, though, that, radiology, sometimes the radiologist is seeing the physician. All of the conditions that we're looking at that go into HCCs have to be from face-to-face care. So, if you think of a radiologist reading a chest x-ray, they're not actually seeing the patient, but an interventional radiologist who is performing a procedure on that patient does have face-to-face interaction. And some of the other things that are on here, one of the things I will point out, even though I'm not a pro-fee coder, I do know about super bills and encounter forms. Those are not something that we can pull documentation from, because they don't become a permanent part of the medical record. And also included in there that's a big deal is the problem list. And I don't think there's anybody in this day and age who's coding from a problem list. I think we all realize there are problems with the problem list. And, just thinking myself going to the doctor and them asking, do you still take such and such a medication? It's like, I took that 3 years ago for a week. And, no, I'm not still taking that. So that comes from the problem list. We are going to talk quite a bit about the plan year, and there's a whole set of terminology associated with HCCs that is different than what we deal with in other areas of coding. And There are a lot of acronyms in this presentation as well. We did include an acronym list at the very end for you. But the plan year, so CMS HCCs are calculated based on the previous plan year. Right now we're in plan year 2019. They are currently operating on a calendar year. And so all of the conditions that were reported last year set the payment rates for patients in 2019. And patients who are either brand new to Medicare Advantage or for some reason don't have any 2018 data have rates pulled from a generic table for new enrollee HCCs. And again, that would include patients who are new to Medicare Advantage or anybody who had coverage in 2018 but didn't go to the doctor. So if they didn't go to the doctor, then there's no data to report for them. There's nothing to analyze, so they get that new enrollee rate. And all HCCs are reset for each plan year.
All right, so this is Shay, and we're going to talk a little bit more about the formula now. So we have shown on the screen the risk adjustment patient payment formula. So the way risk adjustment calculates that per member per month dollar amount is by using this formula. It's the base rate, which the base rate comes from CMS. There, you can view it online. It's by state, by county, and that is multiplied by the risk adjustment factor score. So this looks familiar to other formulas we see for payment. So if you're in the prophy world, looks similar to when we do RVUs times a conversion factor. Or if you're in the facility world, you might be thinking of DRGs, a base rate times a weight. But again, the payments are going to be made to the plans. So like the Medicare Advantage plan, or the Medicare and Medicaid HMO, or an ACA plan, depending on the model. And that covers members' annual care. The CMS, again, the CMS HCC risk model is prospective. So it's going to use that health status in the base year to predict the cost the following year. So that's something Christy had talked about as well. And this slide is just to demonstrate how these risk adjustment factor scores work, what they look like. So it's kind of similar to how car insurance would look at and calculate your risk. So they'd look at your driving record, your commute, your car, your age, credit score, payment history, even your marital status. And those factors affect insurance rates based on the statistics showing how these factors impact how that insurer will pay out claims on your behalf. So it's a very similar idea here. The first one we have is Bob. He's 78 with hypertension, congestive heart failure, and COPD. So his risk adjustment factor is 1.501. So that's taking into account some demographics, which we'll talk a little bit more about that in a little bit. And then Nancy, she's 58 and she has ESRD on dialysis. So she's going to fall into that ESRD risk adjustment model. Her score is 0.824. And then the last one we have is Peter. So he's 72. He has heart failure and a below the knee amputation. So the scores are going to be affected whether or not these diagnoses fall into the HCC model, and then also by the demographics of the patient. So the higher the score, let's see what you guys think on this next question. Kathy?
Okay, so this is when we want to hear from you. So the question is, and Shay was just talking about those three scenarios. So which patient will have the greatest reimbursement? So based on what Shay was just talking about, so our choices are Bob. We're looking at a score of 1.501. Nancy has a score of 0.824, or Peter has a score of 1.265. So which patient do you think will have the greatest reimbursement?
This has to do with the formula we just talked about. So based on that formula, which patient do you think will have the greatest reimbursement?
And we've got responses that are thinking this over, ladies. So we've got more and more people. So I think we're going to have some good discussion. But you're absolutely right, Shay. It was regarding into, you know, the base rate plus or times, I believe is what you said, the risk adjustment payments. So if anybody else wants to weigh in, I'm getting ready to close the poll in 3, 2, 1. And let's go ahead and discuss this. So it looks like we've got the majority of you who are saying at 89% the greatest reimbursement would be for Bob, and then that's followed by Nancy at 7% of our audience, and then the slight minority at 4% is saying it would be Peter.
Yeah, so great job, everyone. That's correct. Bob has the highest risk adjustment factor score, so that's going to yield the greatest reimbursement for that plan to take care of his condition. So, like I said, it's going to be demographics of the patient as well as the conditions, and the conditions have to fall into an HCC category in order to be given a weight. And Christy's going to talk more about the formula next.
All right. So the risk adjustment formula, and I know that if you're brand new to HCCs, this still seems really kind of abstract. I know that I really struggled when I was first starting to get into HCCs of knowing bits and pieces but not really understanding how everything comes together. And I'm hoping we'll be able to fill in some of those holes as we go through today, but we're just giving you some of the kind of basics on how this gets calculated, and then we'll get into, you know, some of the actual HCCs with some of the documentation and stuff here in a bit. But the risk adjustment formula, we talked about the base rate. So the base rate is, as Shay mentioned, is set by CMS, but then there is an adjustment for geographic location. And for today's presentation, we have included Denver, Colorado as our geographic location, since that's where Haugen Consulting Group is based. And the base rate the base rate is set based off of Medicare Parts A and B claims data. So it's, even though our, you know, we think about Part C, they really are using some of our fee-for-service claims and some of our traditional Medicare claims to help identify what those base rates will be. And then you have the patient's risk score. And their risk score, the very first factor is their demographic or their socioeconomic status factors, and that includes the patient's age and the sex, as well as their eligibility for Medicare or Medicaid. They do factor in if the patient is dually eligible, meaning that they have both Medicare and Medicaid, and if they are dually eligible, if they're receiving full or partial benefits. It also takes into account whether they are receiving Medicare based on age or by disability. So if you recall back to Nancy in our last exercise, she was only 58 years old, but she had end-stage renal disease. So she would fall into a category where she received Medicare based on disability as opposed to to age. There is also, they take into account if the patient is institutionalized, living in a SNF or living in the community, And what you're going to find is this demographic, they factor in all this demographic data and give the patient a base risk score. We're going to add to that risk score as we add in diagnoses. And so, for example, Nancy, who was 58 years old, so younger, but also was in Medicare because of disability, had a much lower base rate, a base risk score than Bob did. Bob, who was in Medicare because he was elderly and because he fit into a higher age category, he automatically from the start had a higher risk score than Nancy did. Then we start to add in diagnosis codes, and that's where it gets to be a coding issue, where, you know, Bob, who had, I'm trying to remember now, CHF and COPD and one other thing that I can't think of right now, he had 3 conditions that all had a risk score attached to it. So we add those risk scores to his base score and got his total score. Nancy had the end-stage renal disease, so that was really the only thing that she had. So we added in the end-stage renal disease to her base rate. And you can see how each individual patient then is going to have a personalized base rate. One note here, that CPT codes are not a factor in the HCC formula. And I will say that it's not that they're not important, because Medicare does look at them from a cost perspective of seeing how much it costs to treat these patients, so they can help with set those base rates, but it doesn't go into the individual patient's risk score. So in case you are wondering, right now in 2019, there are just under 72,000 ICD-10 codes, and only about 9,500 of those map to an HCC. So it's, you know, on the hospital side, we kind of think in terms of DRGs, where, you know, every code is going to, you know, potentially generate a DRG. It's not that way in HCC. So it's possible that the patient could come in for a cold or something and not have any other conditions, and then it's not going to generate an HCC. There are 83 HCCs in version 23. So it's similar to the DRG system for those of us who are working on the facility side, where you've got a code and it maps to an HCC. And then there's a hierarchy that's applied there if you have several diagnoses that are related similarly. And then from there, that helps determine payment. But for those of us on the hospital side, it's also like APCs in that we can generate multiple HCCs for a single patient. It helped me to understand HCCs better this way, coming from the hospital side, to kind of relate it to DRGs and APCs as opposed to just thinking of this globally. So within the CMS classification system, they've got these risk tables, and these are all available on CMS's website. We have included links at the end of this presentation on our resource or our reference slide that show you how to get to all of this stuff. But this is what the table looks like. We've simplified it a little bit. It has some additional columns to include the prescription, the RX HCCs, and the ESRD and the PACE HCCs, but we excluded some of the rows here. So within the table, you will, let me see if I can get my pointer up here. Within the table, you'll see the diagnosis code. So you code according to the coding guidelines, you assign this code, and then that tells me that this code E11.11 maps to HCC 17. You'll notice that code E11.21 maps to HCC 18. So there are a couple of different diabetic HCCs that are in there. And it tells you what the RHCC is, again, if the patient has Medicare Part D, and if it's included in the payment model. Now, each HCC has a relative factor, and that would come from a different table. If you're working in HCCs, you've got software that does all of this for you, but there is a way to figure this out without the software. And I can go into another table, look up HCC 17, and see what that relative factor is. That relative factor is like a relative weight, or I think in every other payment model in healthcare, we call it a weight, either, an RVU or a DRG weight or an APC weight. So that concept isn't necessarily new. And that is that relative factor gets added in to that patient's base risk score to help determine what their overall reimbursement is going to be. Shay, you want to do some examples?
Yeah. So on this slide, we just put 3 of the HCC categories up so you can see them. So the first one we have is HCC1, and that one corresponds to HIV/AIDS. So remember, Christy said there was 95 diagnoses that map to an HCC, but there's only 83 HCCs. So there's sometimes there's a lot of codes that fall within an HCC. So here's just some examples. So in this very first one, HCC1, we just have 3 diagnosis codes that fall into this one. So we have the B20, B97, 35, and then the Z21. So kind of what you would expect. And then the risk relative factor is, or the weight, is 0.344. So as long as that one of those diagnoses is reported throughout the year, then that relative factor weight is going to be assigned to that patient. One thing that's important to know is the patient might come back multiple times throughout the year to see their provider for their HIV/AIDS. So that code would be reported on multiple claims form. It's only going to be counted once in this model. And it just has to be reported one time throughout the year. So the next example we have shown is the morbid obesity. So that's HCC 21. So you can see there's a few more diagnoses that fall into that one, all of the obesity codes. And that relative factor is 0.262. And then the last one example we have here is HCC 60, and that's for personality disorder. And that has quite a few codes that fall into it as well. And that has a relative weight of 0.353. So there's a complete list of all ICD-10 codes, similar to what Christy just showed, on the CMS website. And like she said, the link is at the end of this presentation. So here's a list that shows some more of these categories with the weights. And this is just a snippet. So one thing I wanted to point out is if you look at the risk or relative factors, the weight scores, in relation to the HCC number, they don't correlate as far as biggest to smallest. So this gets a little confusing sometimes, but like if you look at HCC 19, which is diabetes without complication, it doesn't have a higher risk factor than HCC 1. It's just the number assigned to the HCCs, and then there's also some numbers that are just completely skipped. So you'll see this goes 1, 2, and then 6. So these weights shown on this slide are for a patient who is aged into Medicare, not disabled, and for a patient that lives in a community rather than an institution. So remember that the weights are adjusted for socioeconomic factors, such as if the patient's disabled or institutionalized, and for those that are dually covered with Medicare and Medicaid, either partially or fully. And another unique thing about HCCs is the hierarchy or the trumping. So those of you guys that work with DRGs are kind of more used to this, but in this model, there is a hierarchy. So some diagnoses will trump one another. So a more severe diagnosis supersedes a less severe diagnosis if both the codes are submitted. So if both codes are submitted, the higher code in the model is going to count, not both of them. So let's look at an example here. Sorry, can you go back one, Christie's? There you go. So if you look at the bottom of this slide, we have diabetes without complication. That is going to be included in the diabetes with complication categories if both of those codes are submitted through the year, because the more severe, the with complications category defines the impact on that case for that disease group. So that's how the hierarchies work. You can look up the hierarchies online again, and if you have software, it would do this for you. But you can see on this slide, diabetes without complication is HCC 19. And then if you look in the row above that, if they have chronic or acute complications, the 19 is going to be included in the HCC 17 and 18. So sometimes that happens where maybe based on provider documentation, you might see complications documented really well and be able to code those. And then the next time there's no complications, you're not able to. So we want to get the complications documented, of course, when appropriate. And here is just another coding example that goes into this a little bit deeper. This patient is a 75-year-old male who's on Medicare only, lives at home, and he's just coming in for an office visit for hypertension, hyperlipidemia, type 2 diabetes with neuropathy, and he also has morbid obesity. So you can see the demographic weight comes in at 0.528. The hypertension does not map to an HCC, and neither does hyperlipidemia. But then once we get to the diabetes with the neuropathy, that's going to be 0.307, and then the morbid obesity, 0.262. So those scores get added up and then multiplied by the base rate, and the base rate we used was for Denver. So the per monthly payment for that year is $99956. So it's a pretty simple calculation once you get the scoring down. And then this next slide talks about disease interactions. So this is something that is also figured into this model. And this is basically like an add-on score or an add-on risk score that gets figured in. And these are for certain disease interactions. So this is if the beneficiary has diseases in each of the categories that are specified as an interaction. So for example, if the patient has congestive heart failure with diabetes, that would qualify for an additional score. And the purpose of this is to recognize that there's certain combinations of diagnoses or conditions that for an individual really increase their medical costs. So again, just think of these like as add-ons. There's also some other disease interactions that are specified for institutionalized members. And one of the examples I have is if the patient has sepsis with a pressure ulcer. So you could understand that there is definitely some increased costs with taking care of patients that have certain disease combinations going on.
Okay, so let's look at back at our coding example from before. We've got a 75-year-old male Medicare who lives independently at home, presents for an office visit for monitoring of hypertension, hyperlipidemia, type 2 diabetes with neuropathy, morbid obesity, and has a new diagnosis of CHF. So again, looking at the base score for this patient's demographics is 0.528, and then adding in the hypertensive heart disease score. You remember that not every code is going to have that HCC, so we have nothing for the hyperlipidemia. We've got all these other conditions, but now we have a CHF and diabetes interaction. So for this same patient who now has this new diagnosis of CHF, the previous reimbursement was just under $1,000. It's now been bumped up to $1,400. And again, this is being reported within a plan year. So this is going to go over into the next year. Kathy, you want to lead us into our second pop quiz, please?
Certainly. So the question is, which of the following does not affect the RAF? Is it patient age, patient gender, diagnosis codes, or CPT codes? So what do you think? Which one of these does not affect the RAF factor? Patient age, patient gender, diagnosis codes, or CPT codes? And you guys are quick on this one. So awesome. I am going to close the poll, giving you your last chance to vote. Anybody else want to weigh in? I'm closing it in 3, 2, 1, so we can discuss this one. But we've got the overwhelming majority is saying CPT codes does not affect the RAF, but we have a couple people who think patient gender might tie into that.
All right, so it is the CPT codes. Remember that this is all going to be based off of our demographic and diagnosis information, and patient gender does play into their demographic data. So we do have different base scores for male versus female within the same age group. And if you think about a lot of the studies where they talk about, heart disease is more prevalent in men than women, or what my mom always told me, marry a guy who's younger than you because they die first. Unless, of course, you want your spouse to die first. But gender is definitely going to impact that. Thank you, Kathy. Let's see. So there are 10 principles that went into developing the risk adjustment model. And this is just to give you some background to let you know why certain codes are included in the model and certain codes are not. And there's additional information on this in the documents that are posted on the Medicare Advantage website, which again, links are posted at the end of this presentation. So the first principle is that diagnostic categories should be clinically meaningful. And so this relates to the ICD-10 codes, and that they need to be reasonably well specified, and you won't find very many non-specific or unspecified codes in the risk adjustment model. And this is one of the reasons why we're pushing documentation improvement so heavily, is making sure that we're not reporting a lot of unspecified diagnosis codes, because that is not going to help the physician get reimbursed for the care that he provides. Principle number 2 is that the diagnostic categories should predict the medical expenditures. And this again is by going back and looking at old claims data and making sure that they have some general idea of how much it costs to treat a patient who has an acute exacerbation of CHF. So those kinds of things to make sure that we really are honing that reimbursement in to cover the patient's costs. Principle number 3 is that diagnostic categories that will affect payments should have an adequate sample size to permit accurate and stable estimates of expenditures. So because everything is based off of previously reported data, if we don't have a lot of previously reported data for a specific diagnosis, then it's excluded from the model. Principle number 4, in creating an individual's clinical profile, hierarchies should be used to characterize the person's illness level within each disease process while the effects of unrelated disease processes accumulate. So we saw that in in the diabetes slide that Shay went over, where you've got your uncomplicated diabetes, but then you have diabetes with chronic complications, and that trumps uncomplicated diabetes. You don't want to get paid for uncomplicated diabetes and chronic manifestations of diabetes. And then by that same account, it costs more to treat a patient who's got acute complications of diabetes, so then everything else gets dropped. But at the same time, we've got certain conditions that don't really relate to each other, and you want to make sure that both or more of your unrelated conditions are all being reimbursed. And then finally, on this slide, principle number 5, the diagnostic classification should encourage specific coding. And again, I think it's kind of a restatement of principle number 1, but really avoiding the use of any of those unspecified codes. Principle number 6 is the diagnostic classification should not reward coding proliferation. I love this. Coding proliferation. I'm going to use this from now on. I call it the Goldilocks rule of coding. We don't code too much. We don't code too little. We got to code just right. And you really don't gain a lot by just adding codes onto here, unless they're not documented, and you don't want to do that. Don't code anything that's not documented. That'll get you into trouble. But principle number 7, providers should not be penalized for recording additional diagnoses, and they call this monotonicity. So if they have, basically what it's saying is nothing should carry a negative payment rate. So you're not going to, excuse me, add on payment scores for one diagnosis and then take them off for another. That's not how this works. Principle number 8, the classification system should be internally consistent. So if you have, and this kind of goes back to algebra. When somebody told me that, I was like, oh no, here we go. I went into coding because I didn't think there would be math. There's math. Anyway, this says basically that if you have a code in category A that pays more than a code in category B, and you have a code in category B that pays more than category C, then the code in category A pays more than category C. So it's, don't think of it as algebra, think of it as common sense. That, of course, kind of going back to the diabetes example, diabetes with acute complications is obviously going to pay more than an uncomplicated diabetes, which would be group C. Principle number 9, the diagnostic classification system should assign all ICD-10 CM codes. So because each diagnostic code potentially contains relevant clinical information, then the classification should categorize all of those codes. But then again, there isn't always payment attached to all of them. And then finally, discretionary diagnostic categories should be excluded from the payment models. So diagnoses that are particularly subject to intentional or unintentional discretionary coding variation or inappropriate coding by health plans and providers, or not clinically or empirically credible as cost predictors, are not going to be used to predict costs. And now I will turn it back over to Shay.
Yeah, so we've talked a lot about what diagnoses are included in the risk adjustment model, but let's just touch on the diagnoses that are not included, because there's clearly lots and lots of diagnosis codes that are not mapped to an HCC code. And that's going to be diagnoses that are vague or non-specific, so like symptoms. There's a lot of diagnoses that have discretionary medical treatment or coding. So one often thought of here is osteoarthritis. If it's not medically significant, so if you think about like a sprained ankle or a laceration, things that typically heal and are not chronic in nature, if a diagnosis that's maybe transitory, or if it can be definitively treated. So things like appendicitis. Appendicitis is treated and then it's gone, hopefully. And then the model also excludes categories that don't add to costs. So any category that doesn't add to costs, as well as categories that are fully defined by the presence of procedures or durable medical equipment. So the model really just focuses on medical problems that are present rather than the services that are offered. So for all diagnoses that are reported, there has to be supporting documentation. So if you're a coder, this is very familiar to you. The model that we have shown here, or the mnemonic, is MEET. So the M stands for monitored, the E is evaluated, the A is assessed, and the T is treated. So we only need one element of MEET to be met, but the more the merrier, so 2 or 3 is always better. The MEET can be found in any section of the patient record as long as you can code from it. You may also hear this as TAMPER, which is just a little bit different, and that one's treatment, assessment, monitor, plan, evaluate, or referral. And you'll hear, is the diagnosis, has the diagnosis been tampered with? And that was created by Brian Boyce. So these were really looked at, and effect was added in that model by Dr. Erica Reamer, and that's in reference to CMS's guideline that says any condition that is considered or affects patient care, treatment, or management should be documented and ultimately coded. And that's in the ICD-10 official guidelines. So this is something you can post for a reminder for providers to make sure and document, so that way you can capture those codes.
So with our diagnosis reporting requirements, this is kind of what everything gets down to. Now remember that we're always pushing the official coding guidelines. So to me, when I read through a lot of these recommendations, it's like, just follow the guidelines, just follow the guidelines. But all of the diagnoses must be explicitly stated. There should be no assumptions from problem lists, labs, meds that are given, or the patient's history. And state the diagnoses in a codable part of the chart. Remember, we can't code from the problem list and certain other documents that are not resulting from face-to-face care for the patient. Document and code to the highest level of specificity, and this is probably the biggest issue that I think we've seen in coding in general under ICD-10 is we're just not getting the level of specificity that's documented, or we're not educating physicians on what we could use to make that diagnosis more specific. And again, everything must be from a face-to-face encounter. Everything must be reported at least once a year. And this can be really tricky with our chronic conditions where the physician may not restate them. You cannot pull documentation from a previous plan year to support your HCC diagnosis, and make sure that you are following your ICD-10-CM reporting guidelines, whether they be inpatient or outpatient, whichever setting you are working from. Other documentation requirements, and this was pretty eye-opening to me, and even as an RHIT with a degree in health information management, I had to ask some friends, phone some friends, on whether this was pretty much standard documentation requirements for signatures and authentication, etc. And I was assured that it is. But this information is pulled from the Risk Adjustment Data Validation Medical Record Reviewer Guidance link at the end of the presentation. And this is saying what needs to be included besides the clinical information. So we need to have at least 2 patient identifiers on every page of the document. For hospitals, not a big deal. We're used to this. We're used to having patient name, account number, medical record number, date of birth, everything on every single page of a document. In the physician office, this might be something that's kind of new. Patient name and date of birth are fine for your identifiers. You need to have the date of service, and each signature should correspond with a single date of service. So if you have a signature at the end of a page that reflects multiple dates of service, that is unacceptable. Other things that are unacceptable for provider signatures, they have acceptable provider signature with credentials. And this was where it was pages, and I was like, oh my gosh. I sent it to one of my HIM friends, and she's like, yes, Christy, you're fine. But stringent signature requirements for both electronic and handwritten signatures. All signatures have to contain a physician and practitioner's name and credentials along with the date signed, and that must be within 180 days of the encounter. Now, the 180 days is an HCC thing. That's not a general medical record management thing. Signatures that are older than 180 days require CMS generated attestation for the physician, practitioner, office, or hospital outpatient visit, but not for the inpatient side if it happens to be on inpatient. And this one's my favorite. It has to be legible. If you're still doing handwritten records, then it has to be legible. If it's not, if a Medicare Advantage reviewer cannot read the note, then they probably will deny payment. So handwriting counts. So validating the HCC documentation, if you are looking to make sure that your documentation is acceptable, I recommend going into this RADV document. RADV is a risk adjustment data validation that I was talking about on the previous slide. They also have a shorter version, a RADV checklist that kind of summarizes all of that. And it looks kind of old because it's got a date on there from 2010, but it is still acceptable. I think there's reference to ICD-9 codes, just, make that ICD-10 instead. But know what they're looking for. MAO is Medicare Advantage Organization, and they will be pulling records and doing audits on either randomly or anything that is falling out and looks like a red flag. So if you had a sudden jump in the patient's risk score, they're probably going to pull that and look at it and double check. So watch for extreme fluctuations in your risk adjustment factors, and those could potentially trigger an audit. Now, the OIG recommendation, and I got this from a friend who was a reviewer for one of the Medicare Advantage organizations. She told me that the OIG recommends 10 audits per physician per year. She felt that that was kind of low. She would recommend 10 audits per physician per quarter. So something just to keep in mind. And she also did tell me that there was a list of top HCC codes that they're targeting, and that's what this list is here. Shay?
Okay, so some of the missing or unspecified diagnoses, these are kind of the most common ones that we see. Diabetes is a type 1 or type 2. We don't want to use a unspecified one. And then if they have complications, so any manifestations of the diabetes, because remember, those are going to be a little bit higher HCC score. And then depression, if they have an old myocardial infarction, renal failure, and then cancers, the big one is metastatic cancer. And then there's just an example here on the bottom of the slide. If the patient is just documenting hepatitis C, or I'm sorry, if the provider is just documenting hepatitis C, that doesn't map to an HCC code, but if they are specifying it's chronic hepatitis C, that does map to HCC 29. So some of the documentation really does make a difference.
And quickly, some of the things that are commonly missed are a lot of the status Z codes. For example, a history of an organ transplant, HCC 186, major organ transplant or replacement status. That it happens to include all organ transplants with the exception of a couple that are listed here. I thought that it was interesting that kidney transplant, it doesn't group to an HCC, but it does have an RX HCC if the patient has Medicare Part D. So make sure that you are picking up all of those Z codes as appropriate. Some other commonly missed status codes, dialysis status. This one's really important. We have HIV, but also dialysis status. This one's important because dialysis trumps chronic kidney disease stage 5. And we typically think of end-stage renal disease as a stage 5 CKD on dialysis. But it's not, this code N18.6 alone will not give you the risk score that you should be getting if that patient is on regular dialysis. So those status codes are really important. Also, codes for ventilator dependence, amputations, artificial openings, and body mass index over 40. All of these are commonly missed on HCC audits. Kathy, I know we're close to time, but can we fix in one more pop quiz?
Okay. Let me bring it up, launch it. So the stage 5 CKD HCC trumps the dialysis status HCC. Do you think that's true or false? And we'll just do this really quick because we are right at the top of the hour. The stage 5 CKD HCC trumps the dialysis status HCC. True or false? Okay, I'm going to close the poll. Here's your last chance. 3, 2, 1. Okay, we've got the majority, 88% is saying this is a false statement, but we do have 12% of our audience is saying it is a true statement.
And this one is false. And I think at least from a facility perspective, it's hard to think of a status code having a payment impact, but it definitely does under HCCs. It's a different way of thinking, and it is important to understand the trumping rules in the hierarchies. Thank you, Kathy. So just one last plug for the coding guidelines. Make sure that you know your ICD-10 coding guidelines. I see a lot of discussions by new coders who have learned under the HCC model, and I see them asking a lot of what I consider to be basic questions where the answers are found in the coding guidelines. Remember that Section 1, which includes the chapter-specific guidelines, applies to every healthcare setting. And if you are coding in the physician office or for hospital outpatient, we're looking at Section 4. For hospital inpatient, we're assigning code or looking at the guidelines in Sections 1 and 2.
All right, so we are kind of running out of time, but just to wrap this up, we just want to talk about why you should know this. So remember that all of this is the Medicare Advantage plans and the CMS model. They are being reimbursed based on what the providers submitted HCC codes. So it's going to kind of trickle down from there. The provider may or may not be reimbursed based on HCCs, but it is going to affect how much money that plan has to take care of the patient. So there is a little bit of a disconnect there. Providers are asked to document HCC conditions, but they may not be reimbursed for them. Providers are going to be accustomed to being paid by CPT or HCPCS or E&M services that they rendered. But if the providers are paid based on HCCs, the reimbursement amount will be based on services provided for the patient, but not paid for until the anticipated future cost or that next year when the services may be rendered. So there's a little bit of a hurdle there in promoting that detailed documentation, but it really goes into correct data and how that data is being used. So some of the more telling ways it's being used now is to demonstrate a provider that's really caring for sicker patients in that high quality cost model where they're looking at the cost of taking care of these really sick patients. So it is going to kind of trickle down. And we were just kind of thinking of the analogy of Wimpy and Popeye. And we have our little bee. So they'll gladly pay you Tuesday for a hamburger today. Christy, do you have anything to add?
I think that really pretty much covers it all. I just wanted to one last time point out we do have an acronyms list in case there were things in here you weren't familiar with. We've got our reference list that we referred to frequently throughout today's presentation, and I know that we're over time. I want to thank everybody who stayed with us. And if you do have questions about today's presentation, please shoot us an email and we will be sure to get those answered and get them into our YouTube video. And Kathy, you want to bring us home?
Absolutely. Thank you, Christy and Shay, for a wonderful presentation. And as you can see on your screen right now, and it is in your handout, there's the YouTube channel. So we did have some questions come in, but I believe Shay and Christy went ahead and answered them and shout out the responses to the entire group. But we will go ahead and wrap those in and make this video so it will be available to you probably late next week. So please take a couple minutes to fill out the survey. Let us know what you thought about today's presentation and any hot topics you might have, and look for an email within 48 hours that will provide you with the recording link and the materials that you can view on demand. So again, thank you so much for your time and attention this afternoon, and we hope to see everybody next month. Thanks. Bye-bye.